And Dr. Gottlieb, it's great to see you again this morning. I kind of use you as my touchstone to run through everything I've been thinking about overnight to figure out where we're headed next. And I think what I've been thinking about a lot lately is what happens with asymptomatic cases? How are they spread? How do we control this? And if we don't have enough tests to even test the people who are on the front line, some of the healthcare workers at this point, how can we possibly get to the point where we have enough tests to make sure we're testing even people who are asymptomatic to make sure that it's okay to go back to meet maybe the rest of your family, go back to work, go back to school?
Yeah, well, we're not going to be able to, Becky. That's the challenge with this virus, is that there's so many people who have mild disease or asymptomatic. Anywhere from 10 to 20%, if you look at the different studies, are asymptomatic, and a lot of people have mild disease. And that's what makes this such a dangerous pathogen, why it's so amenable to becoming a pandemic. If you think about SARS and MERS, those pathogens were very deadly, and most people who got infected with them got very sick. So they were easily identifiable in a population. If you had 100 cases of SARS in a city, you'd know it. You could have 1,000 cases of coronavirus in a city, and you might not know it because most people would have mild disease or be asymptomatic, and just a small percentage would present with influenza-like symptoms. And that's, in fact, what happened in Seattle. And that's why this pathogen is so lethal and so deadly. We talked about it hitting that sort of sweet spot early on in January. We were talking about that on your show. And it sort of occupies that sweet spot between being virulent enough that it's going to cause mass casualties if it gets into a big population, but transmissible enough that it can spread fairly easily. And the asymptomatic spreaders are part of that. There was a study in Lancet out this week that showed that people who were mildly infected with the virus didn't really develop full antibodies till about 2 weeks, and they continued to shed virus after that as well. It's not clear if they're still infectious after they develop antibodies, if they're still shedding virus, but you can surmise that they probably are. If they're still shedding virus, if you can still get a positive nasopharyngeal sample on them so they still have virus in their nose, chances are there's a risk that they can still spread it. And so that's another thing that makes this virus risky or makes it spread very easily, is that after you get sick with it, you don't clear it right away. Some people seem to shed it for a period of time.
That's hugely important. Even friends I have who are healthcare workers, nurses and doctors, are being told that as soon as they feel better, they should get right back to work. They're also being told that there's an assumption that every healthcare worker has been exposed at this point. So if you're not very sick, we're not going to test you. How is this even possible?
Well, some places are retesting people to see if they've cleared the infection, and some of the guidelines do have a period of time that you want to wait before you get back to not taking precautions around the potential to spread the virus, because there's now enough literature that shows that people don't clear it right away. So you see people with antibodies, but still with virus that they appear to be shedding. And with a lot of other viruses, or some other viruses, after you develop antibodies to the virus itself, you no longer have detectable virus. With this one, it's a little different. In terms of the number of healthcare workers that have been exposed and what we call seroconverted, meaning developed antibodies to the virus, so they basically developed some level of immunity, I think the percentage is likely to be lower than what we think, more in the order of maybe 10% or less in cities that are heavily exposed to this virus than 20 or 30%. I think the perception that there's this vast pool of people out there who've already been exposed to this coronavirus and have neutralizing antibodies, have immunity to it, I think that that's probably overstated. And when we do the serology tests on populations, even heavily affected populations like New York, it's likely to be in the low single digits. So, the view that this virus has been spreading here for a while and we just didn't detect it is probably not the case. Every country that this virus has gone into, it's been fairly consistent. About 80% of people develop mild to moderate disease, maybe 10 to 20% are asymptomatic. About 10 to 15% develop more severe symptoms, require hospitalization. Anywhere from 3 to 5% require a higher level of care in the intensive care unit, and then about 1% succumb to the virus. That's been fairly consistent from country to country, and I don't think the experience is going to be any different here. There's not millions of New Yorkers who've had coronavirus and just didn't know it, and now they're immune to it. More likely, those people who remember having a bad bout of some kind of respiratory illness in early January had adenovirus or flu or something else, but not this.
All right. Hey, doctor, separately wanted you to weigh in on this. There's a whole lot of people, including in the business community, who say, look, the goal here, of course, in terms of flattening the curve is so that we don't overwhelm the healthcare system. But once we've done that and get to even any real backside of the curve, that we should try to get back to business as quickly as humanly possible. And to the degree that the hospitals can handle it, we've done our job. Is that analysis the accurate way to think about it? Because I think everyone's looking at the duration of this and saying, okay, we see where the curve is, and what's the goal? Is the goal to eradicate it? Obviously, that's the ultimate goal. But in terms of how you're thinking about it.
Well, I don't know that we're going to fully eradicate it. There's going to be a low level of spread. As we come down the epidemic curve, there's going to continue to be a low level of spread. And even if you look at South Korea, they're still reporting cases on a daily basis, less than 100 cases, but they're still reporting cases every day. So there's going to be some background spread of this virus, and there might be some background spread of this virus in perpetuity that we just need to accept. And if you think of deadly viruses throughout history, throughout the last century, there was always background spread. I mean, there were always outbreaks before there was vaccines of measles and polio. You always had spread in the background. You tried to contain it.
Could there ever be enough community spread that actually
unlikely
really goes back up again, that it becomes a problem in terms of the healthcare community being able to handle it afterwards, after this curve?
Potentially, and that's what you worry about. I mean, if we don't get control of this, we can have another epidemic in the fall, and that's where we need a very aggressive surveillance system and hopefully a therapeutic that can vanquish this. But we're going to have to tolerate some low level of spread and lean forward and try to open the economy and just contain the cases that are going to emerge. There's going to be small outbreaks.